Motor system is examined under following headings, and these points are very useful in examining the patient of hemiplegia: nutrition, tone, power, coordination and involuntary movements. So, first will be examination of nutrition of muscle. Nutrition is tested by measuring circumference of muscle at its bulk and comparing circumference of left and right side. So, circumference of the calf muscle can be measured by fixing the distance from bony prominence, that is 6 inches from the tibial tuberosity. Measure the circumference of right and left calf muscle at the same distance. So, we are measuring the calf muscle by a tape. This is the nutrition of muscle. Nutrition of muscles. We are testing motor system of the nervous system. Similarly, circumference of the thigh muscle from a fixed bony prominence like tibial tuberosity or anterior superior iliac spine can be compared. In the same manner, for the upper extremity, circumference of the forearm and arm muscle can be compared from a fixed bony prominence like olecranon process. So, in the same manner, the circumference of the arm muscles can be compared from fixed bony prominence like olecranon process. When the circumference of both right and left side is normal, it indicates the nutrition of these muscles is normal. So, we are examining the nutrition of the muscle. In the right-sided person, circumference of right-sided muscle can be slightly more. This is physiological. Atrophy of the muscle is seen in lower motor neuron lesion like poliomyelitis. So, we have tested the nutrition of the muscle. We have tested the nutrition of the muscle, that is the examination of motor system. Next, second, tone of the muscle, samvanana. Tone of the muscle is a partial state of contraction. It is maintained by stretch reflex. Tone of the muscle is tested by two ways. Number one, by examining the feel of the muscle. Tone can be seen by resistance offered by passive movements. So, this is feel of the muscle at its bulk, and it can be compared feel on the right side and feel on the left side. Doctor can observe the feel of calf muscles, thigh, muscles of the bicep, muscles of the tricep. Normal feel is elastic. Normal feel is elastic. This is the tone of the muscle. This is the tone of the muscle. Feel is elastic. Second method of examination of tone is to see resistance offered to passive movements. Patient is not moving his extremities, but the doctor is carrying out passive movements. Doctor can do passive movements at knee joint to test the tone of the flexors and extensors of knee. Flexure and extensors of knee. When doctor is doing flexion of the knee, he is testing the tone of extensors. When doctor is doing the extension at the knee, he is testing the tone of flexors. See, when we are doing the flexion, it is the extensors. Extension, then we are tone of the flexors that we are testing. So, this is the tone of the muscles. For testing upper extremities, same movements can be done at elbow. Doctor can test tone of the bicep and triceps, and he can compare the tone at other side. When doctor is carrying out flexion at the elbow, he is testing the tone in tricep. When the doctor is carrying extension, the elbow is testing, the tone is bicep. In lower and upper extremities, when resistance offered is moderate, it indicates the tone is normal. In hypertonia is seen in UMN lesion, hypotonia is seen in LMN lesion, upper motor neuron and lower motor neuron. Power of the muscle. Third part is the power of the muscle. Power is graded under 5 grades as follows. Grade 0, no movements at all. Grade 1, only flickering movements are visible but no movements are possible. Grade 2, if movement is occurring horizontally but not able to lift against the gravity. Now, see, against horizontally, the movement can be done horizontally but not able against the gravity. That is grade 2. Now grade 3, lift up the leg or the hand against the gravity. Compare the right and left side. This is grade 3. Now the patient is able to move his extremities against the gravity, grade 3. We are testing the power of the muscle. Now grade 4, patient is able to move his extremities against gravity as well as against resistance. Doctor is pressing the hand and is lifting the leg. So this is grade 4. Power of the muscle is grade 4. Power of the muscle grade 4 against the gravity and against the resistance. And grade 5 is the normal. Patient is able to lift the extremities against the good resistance by the doctor. Against the good resistance of the doctor. This is grade 5. Doctor is pressing and is lifting the legs. This is normal. This is normal power, grade 5. Grade 5. Right and left. Left and right. Test both the sides always. This is the examination of power of the muscles. Central nervous system examination, we are examining motor system. We have examined the motor system. In the same manner, power of the extensors of the hip, flexors of the knee, extensors of the knee can be compared. Even plantar flexors, dorsiflexors of the foot can be compared. In upper extremity, flexors and extensors of elbow can be compared. Flexion and extensors of the wrist, can be compared. Movements of shoulder such as flexion, extension, abduction, adduction can be tested for power. For testing the power of the neck muscle, patient is asked to lift his neck in lying down position. See, testing the neck muscles. We are testing the power of the muscles. Complete loss of power is called as paralysis, which is a typical feature of lower motor neuron lesion like poliomyelitis. Partial loss of power is called as a paresis, which is typically seen in hemiplegia or paraplegia. So, power of the muscle has been tested. Power of the muscle is tested. Next will be coordination of muscles. Coordination of muscles in upper extremities is tested by following test: finger nose test and rapid pronation and supination of palm, that is diadechokinesis. So, coordination of muscles for upper extremities. Coordination of muscles for upper extremities. Dr. Joshi is explaining how to test the coordination of muscles in upper extremity and lower extremities. First, let us see finger, nose, finger test. Finger, nose, finger test. The patient has to do with the open eyes first and then with the closed eyes. This is the coordination of muscles. Finger, nose, finger test for upper extremity. Coordination of muscles. we are testing motor system of the nervous system. Finger, nose, finger test. Coordination of muscles. Finger, nose, finger test with closed eyes and open eyes both. First with open and then with the closed eyes. Next is a rapid pronation and supination of the palm. That is didacokinesis. Didacokinesis. Coordination of muscles in upper extremities. Rapid pronation and supination of palm. Didacokinesis. 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 Rapid pronation and supination of the palm. Didacokinesis. Didacokinesis. Coordination of muscles in upper extremities. Now, next will be for lower extremities. We will test the coordination of muscles in lower extremities. First with the open eyes and then with the closed eyes. Knee heel test. Knee heel test. He has to go down, first touch the heel to the knee and then go down up to the foot. Knee heel test. Knee heel test. Coordination test for the lower extremities. Coordination of muscles for lower extremities. Knee heel test, first with the open eyes and then with the closed eyes, to see the difference in between sensory ataxia and cerebellar ataxia or motor ataxia. Sensory ataxia or cerebellar ataxia. So this is the knee heel test. Knee heel test. Coordination test for lower extremities. Coordination test for lower extremities. Now the next test is walking in a straight line. Walking in straight line. The patient has to stay on one line. First keep the eyes open, then walk in a straight line, and while returning close your eyes. So this is a walking in straight line test. Walking in straight line test. This is the test for coordination of muscles in lower extremities. Coordination of muscles in lower extremities. Now the last is a rhombus test. The patient has to stand straight and he swings with the closed eyes. It is called as a positive rhombus test, which is the typical sign of dorsal column tract damage. So we are doing the coordination test for lower extremities. First is walking in straight line. Walking in straight line. First with the open eyes, then with the closed eyes. If patient walks correctly with open eyes but loses balance with the closed eyes, it indicates the damage lies in the dorsal column tract, which is called as a sensory ataxia. If the patient is not able to walk with open or closed eyes, damage is in cerebellum. It is cerebellar or motor ataxia. Cerebellar or motor ataxia. So next will be involuntary movements. So three types of the involuntary movements can be seen, like a tremors. We have just now tested the coordination of muscles in lower extremities. Walking in straight line and also doing the rhombus sign. Now involuntary movements, fine tremors in thyrotoxicosis. Fine tremors in thyrotoxicosis. Pin rolling tremors at rest in Parkinsonism. Pin rolling tremors at rest in Parkinsonism. Then action tremors in cerebellar disease. Action tremor in cerebellar disease. So advantage of motor system examination over sensory system is that even if the patient cooperation is not there, we can draw few conclusions like UMN, tension or LMN lesion, Parkinsonism, cerebral ataxia, sensory ataxia. In sensory system examination, if the patient is non-cooperative, then he cannot answer the doctor questions and the examination is of no value. However, sensory system examination is important to detect the level of damage in spinal cord. So this is the comparison of motor system examination and sensory system examination. Now, examination of reflexes. Reflexes are classified into groups: superficial reflexes, conjunctival reflex, corneal reflex, pharyngeal reflex, deep reflexes, bicep jerk, tricep jerk, supinator jerk, knee jerk and ankle jerk. Superficial reflexes receptors are in skin and mucous membrane, and in deep reflexes receptors are in muscles or tendons. So, first is a superficial reflex. Conjunctival reflex. Doctor will touch with the whip of the cotton wool to the white portion of the eye, that is bulbar conjunctiva. Response is closure of both the eyes. Conjunctival reflex, superficial reflex. Now, corneal reflex. Doctor will touch the whip of the cotton wool to the black portion of the eye, that is cornea, and closure of both eyes is a normal response. Corneal reflex. Conjunctival and corneal reflexes have already been tested in examination of trigeminal and facial nerve. If these nerves are damaged, reflexes are lost. Conjunctival reflex and corneal reflex. Palatal and pharyngeal reflex. Next is a palatal and pharyngeal reflex. The doctor will touch soft palate or posterior pharyngeal wall with the tongue depressor. Doctor will expect a response in the form of coughing. If the patient is getting coughing sensation, it means 9th, 10th and 11th cranial nerve involving in this reflex are normal. Palatal and pharyngeal reflex. Now, next is the abdominal reflexes. Important precaution to be carried out is that abdomen should be relaxed by flexing the knees. Abdomen should be relaxed. Now, the blunt end of the hammer is moved, radiating away from umbilicus in all directions. Blunt end moved away from the umbilicus. This is abdominal reflex. While testing, the reflex of abdominal muscle will show a movement in the form of response. Abdominal reflexes are classified into upper abdominal, mid-abdominal and lower abdominal reflexes. Root values of the reflexes. Upper abdominal reflex T6 to T9, mid-abdominal reflex T9 to T11 and lower abdominal reflex T11 and L1. In obese patients, abdominal reflexes may not be elicited. In such cases, unilateral absence of abdominal reflex is important finding. Abdominal reflexes are lost in UMN lesion like hemiplegia or paraplegia. All this is about abdominal reflex. Now, plantar reflex. Root value of the plantar reflex is L5, S1 and S2. We have to scratch the sole of the foot from heel to toes along the lateral border and then medially. This scratching is done with the blunt portion of the hammer. We compare it with the other side. Normal response is a plantar flexion of all toes. Plantar flexion. If dorsiflexion of the grade 2 and fanning of the other toes is seen, then diagnosis is positive plantar reflex or positive Babinski's sign. This will be seen in UMN lesion like hemiplegia or in meningeal irritation, that is meningitis. So we have tested plantar reflex, that is Babinski's sign. Plantar reflex or Babinski's sign. Now, the bicep jerk. Bicep jerk, for testing, remember, for testing deep reflexes, special method is adopted, that is Gendrasik maneuver. By this maneuver, gamma motor neuron discharge is decreased and reflex is obtained properly. So this is Gendrasik maneuver. Gendrasik maneuver, the patient is asked to close his teeth tightly or tight his fingers. Gendrasik maneuver, to divert the attention of the patient. Gendrasik maneuver, to divert the attention of the patient. Bicep jerk, clench the teeth tightly. Bicep jerk, doctor will tap bicep tendon. Contraction of the bicep muscle is important rather than flexion of the forearm. We compare the reflex on both sides. Root value of this reflex is C5 and C6. Bicep, contraction of the bicep muscle. Contraction of bicep muscle. Bicep jerk. Bicep jerk. Now, tricep reflexes. Doctor will give tap just above the olecranon process, which is a tricep tendon. Contraction of the muscle is more important than extension of the forearm. Contraction. Contraction of muscle is more important than extension of the hand. Compare the reflex on other side. Root value of this tricep reflex is C7, C8. C7, C8. Now, supinator reflex, wrist jerk reflex. Tap is given just above the head of the radius. Head of the radius. Doctor can see the contraction of brachioidalis muscle. Compare the reflex on another side. Root value is C5 and C6. Now, the deep reflexes in lower extremity, that is knee jerk. For testing this reflex, exposure of the quadricep muscle is important, so that the doctor can see the contraction of this muscle. Doctor keeps his hand below the knee. Patient is asked to relax, divert the attention by Gendrasik maneuver, and give the tap on patellar tendon, that is between patella and tibial tuberosity. Patellar tendon. Contraction of the quadricep muscle is important. Response. Root value is L2, L3 and L4. Knee jerk. Now next is ankle jerk. Ankle jerk. These are the deep reflexes. For this reflex, gastrocnemius muscle should be exposed. Gastrocnemius muscle. Tapping of the gastrocnemius tendon just above the heel is stimulus. Doctor will make forceful dorsiflexion of the foot and give a tap on tendon. Contraction of gastrocnemius is the response. Compare the reflex on the other side. Compare the reflex. Root value is L5, S1 and S2. Examination of the reflexes is most important part in examination of nervous system. Advantage of this examination than motor and sensory examination is that it does not require patient's cooperation. Various diseases, especially the UMN lesion and LMN lesion, can be differentiated by examination of deep reflexes. Even if the patient is unconscious, non-cooperative, these reflexes will give important clues. In UMN lesion, deep reflexes are exaggerated. Jerks will be very much prominent. Even clonus can be seen at knee and ankle. Clonus, where muscle jerk oscillates for longer time. Clonus is always pathological and it is seen in the UMN lesion. So we have done the examination of reflexes, examination of deep reflexes in upper extremities as well as in the lower extremities. We are testing now the examination of spine and cranium. Spine and cranium. Spine is to be inspected from cervical to sacral region for noticing abnormality. With knuckles of the fingers, doctor can give the deep pressure on spine and ask the patient whether he gets pain sensation. For testing cranium, afterwards, cranium. Deep pressure is to be given on skull from all angles and patient is asked whether he gets pain sensation. If there are abnormalities of the spine, if there are conditions like hydrocephalus, the test will give intense pain. So this was examination of spine and cranium. Now, examination of gait. Circumduction gait in hemiplegia, jerky gait in Parkinsonism, drunk man's gait in cerebellar disease, spastic gait in paraplegia, flaccid gait in poliomyelitis. So, Professor.R.R.Joshi will lastly in the session will show the examination of gait, how the patient will walk. Accordingly, we can diagnose the disease. Now, first is a circumduction gait in hemiplegia. Professor Dr. Joshi is obliged us by showing the circumduction gait in hemiplegia. Gait is a style of walking. Circumduction gait in hemiplegia. Now, next, jerky gait in Parkinsonism. Jerky gait in Parkinsonism. Jerky gait, G-A-I-T, in Parkinsonism. Jerky gait in Parkinsonism. Jerky gait in Parkinsonism. Jerky gait in Parkinsonism. Jerky gait in Parkinsonism. Then, drunk man's gait in cerebellar disease. 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 So this is all about the examination of nervous system video. This is the last, that is called as a polio gait, flaccid gait with poliomyelitis. Flaccid gait of poliomyelitis. This is nearly the end of central nervous system examination video. So thank you very much.